Two.
The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. This is Güliz Barkan. I am the president-elect of the American Society of Cytopathology, and you are now listening to the ASC's educational webinar series. Our guest today is Dr. Barbara Centeno. Dr. Centeno graduated from the Johns Hopkins School of Medicine and completed her AP residency training at the Massachusetts General Hospital, where she served as the chief resident in anatomic pathology. She then completed her cytopathology training also at the Massachusetts General Hospital. Currently, she's the director of the quality assurance for AP and the director of cytopathology and a senior member at the Moffitt Cancer Center and a professor at the Morsani College of Medicine at the University of South Florida. She's actively involved in cytopathology, fine needle aspiration, frozen sections of gastrointestinal pathology services. She also is one of our wonderful executive board members, and I thank her very much for volunteering for her to give us a session on the practical approach of liver cytology. There you have it, Barb.
Thank you. So as Dr. Güliz mentioned, my focus today is going to be on liver cytology. And I have to learn how to advance. How do I advance my screen?
If you're arrows on there, you have it.
It doesn't work from my keypad. So I'm going to, a couple of basic topics. I'm going to give a little bit of a background. I'm going to review the cytology of benign liver and benign liver nodules. Then I'm going to review some basics about the cytology of the two main primary liver cancers, hepatocellular carcinoma and cholangiocarcinoma. I will review some of the ancillary studies indicated for some of the key differential diagnoses. I'll touch upon metastases, and then I'll go into a couple of cases to test some of the principles that I'm going to present during the lecture. The primary indication for liver fine needle aspiration is to evaluate a mass. As we see here, here's a CT scan showing a large irregular mass in the right lobe of the liver. And typically, the liver can also be home to cystic lesions, but I'm going to focus mostly on solid lesions. But there's a large number of entities that can occur, ranging from non-neoplastic or benign neoplasms such as hemangioma to benign liver nodules, primary epithelial cancers, less common non-epithelial neoplasms and malignancies, for example, epithelioid hemangioendothelioma or angiosarcoma. And then the liver is more commonly the site of metastatic disease than of primary cancers. And there's a number of key diagnostic issues with which we're faced when evaluating a liver aspirate. The first and foremost is distinction of benign or reactive hepatocytes and non-neoplastic liver or benign liver nodules or neoplasms from well-differentiated hepatocellular carcinoma. The other challenge is when we're presented with a poorly differentiated neoplasm and we need to differentiate poorly differentiated hepatocellular carcinoma from cholangiocarcinoma or metastatic disease. When faced with metastases, the other challenge is determination of primary site of origin of metastases. And lastly, another key problem, which I'm really not going to focus on today, is determination of histogenesis of poorly differentiated malignancies. And what's key here, as probably you've heard from other presenters, is that an approach to the liver lesion really needs to present with an understanding or knowledge of some key components of the clinical history, specifically age and gender, because these might predispose the patients to certain kinds of diseases. It's key to know whether the patient has any kind of underlying liver disease that might predispose them to hepatocellular carcinoma or cholangiocarcinoma. It's important to know if they have a previous history of carcinoma. It's also important to know the radiological findings. What does it look like? Is it well defined, or does it have imaging features to suggest hepatocellular carcinoma? Is it multiple liver nodules to suggest maybe metastases? Then we evaluate the cytological findings. and add ancillary studies as indicated. And then the end result or report should be a correlation of all of these components. These images demonstrate what normal hepatocytes look like. Typically, they occur in trabeculae that are 1 or 2 cells thick, as we see here. Here's a single cell trabeculae. They have abundant, granular, well-defined cytoplasm and centrally located nuclei. We can see them here on DiffQuick with well-defined cytoplasm. It looks a little bit more granular or vacuolated, and we see the nice round centrally located nuclei. Normal hepatocytes will contain a number of pigments, which we can see these on cytology. Bile is golden yellow and located either in the canaliculi or else within the cytoplasm. It's darker, appears black on DiffQuick stain, but again, here we can see it within the canaliculi, and in the cytoplasm, it forms large granules. Lipofuscin forms a granular golden yellow pigment within the cytoplasm. It's a little darker gray and duskier on DiffQuick. Bile duct cells are the other component of normal liver that we are going to see on an aspirate of benign liver or benign liver nodules. These cells are columnar. They're smaller in overall size than hepatocytes. They form flat sheets in a honeycomb pattern, or if we see them on edge, we might see them on edge here. They look more columnar, but the nuclei here are basally located, round, and uniform. The differential diagnosis of benign liver nodules includes macroregenerative nodules, foci of cirrhosis with dysplastic nodules, focal nodular hyperplasia, and adenoma. All of these have common cytological features, which include benign or reactive hepatocytes in irregular sheets without peripheral endothelial cell wrapping. Typically, there's a mixed cell population, except in adenomas. Typically, the diagnosis or definitive diagnosis in this situation is really improved by having a cell block with a good microhistology sample or a core biopsy. And again, it's important to correlate with clinical and radiological findings for definitive diagnosis. And the key here is typically when we're faced with something that's composed of benign appearing hepatocytes, the key differential diagnosis is with well-differentiated hepatocellular carcinoma. And I mentioned a few benign nodules. I'm going to focus on 2. The first of these is focal nodular hyperplasia. It's thought to be a non-neoplastic response to altered blood flow. Typically, they're solitary, but they may be multifocal. They tend to be more common in females. If we were to see a resection specimen, it's typically well-defined with a central stellate scar. On histopathology, it's characterized by plates of benign liver with fibrosis and blood vessels that are thickened with an eccentrically thickened muscular wall. And then we see a bile ductular proliferation. It somewhat mimics cirrhosis. This is the characteristic feature of focal nodular hyperplasia or any one of these reactive nodules on cytology, and that is the presence of reactive hepatocytes. These are characterized by groups that show irregular, jagged edges. It lacks peripheral endothelial cell wrapping or a significant amount of transgressing endothelium. When we look at the cells, they're 1 to 2 cells thick. So the plates, it lacks wide and trabeculae. We have some single cells. Here we have a bile duct. The cells have a low nuclear to cytoplasmic ratio. We may see binucleation. Here are a few more examples. Again, here we see some benign liver. Here there's a bit of inflammation and crush artifact and lymphocytes. Notice the cells, sorry about that. The cells have a very low N-to-C ratio. Here the cells, we have a bile duct with all of these reactive hepatocytes. Notice the nuclear pleomorphism, meaning that there's a lot of variability in the shape. In the size of these nuclei, although they're all rounded. Notice that there's an inflammatory component here. There is some endothelium. Here you can see these elongated capillaries or endothelial cells of a capillary. Sometimes the nuclei will show degenerative changes, and sometimes we do get stripped nuclei with reactive hepatocytes or benign hepatocytes. Hepatocellular adenoma typically occurs in non-cirrhotic liver, and our understanding of what drives the development of these has increased over the last decade or so. So we now have a molecular classification of adenomas. But in general, in terms of morphology, on gross exam, if we were to look at a liver, we can see that it's a well-defined mass. Here it has some bile pigments, a little greener compared to the normal liver, but notice that it's very well-defined and located beneath the capsule. When we look at histopathology, this particular adenoma shows a lot of steatosis and one prominent vessel. They're characterized by the presence of blood vessels without paired bile ducts. And if these trabeculae are only, or these liver cell plates are only 1 to 2 cells thick. And then here's the characteristic cytology. It's really similar to the reactive hepatocytes or benign hepatocytes that we've already seen. You can see that the cells are arranged in trabeculae or in groups that are one cell to 2 cells thick. Here it lacks any significant vascularity. You can see that the cells have a low nuclear cytoplasmic ratio, and there's some variability in nuclear size. The only thing that differentiates this from the other nodules that I showed you is the absence of bile ducts, and that's the characteristic feature of adenoma, is the absence of bile ducts. I mentioned that there's been a lot of progress made in understanding what drives the development of these adenomas, and there have been 4 basic subtypes described. And these types, we're not going to necessarily differentiate these on cytology, but typically we'll get a cell block or microhistology, and typically the clinicians increasingly want to know what kind of adenoma the patient has in order to decide treatment and risk of bleeding. And this table summarizes those subtypes. The first type that occurs more commonly in females is associated with a mutation in the HNF1A gene, and it's characterized by abundant steatosis. And we could also identify it by doing immunohistochemistry for liver fatty acid binding protein, which will be lost in this particular type of adenoma. Then there's an adenoma characterized by beta-catenin gene activating mutations. And this one actually occurs more commonly in men and has more cytological atypia. And this one would be characterized by increased nuclear beta-catenin expression. Then there's an inflammatory type, which is probably the second most common, and it's associated with abnormalities in pathways involved in inflammation. And it has a distinct histomorphology. But again, I don't know that we would be able to differentiate these based on cytology alone. And it also has a characteristic immunophenotype showing strong serum amyloid A expression and C-reactive protein expression with some other typical expression patterns. The subclassification has been further defined, and there have been a few other, let's say, specifications identified, and that is that sometimes adenomas, like initially when they were described, the mutation identified in beta-catenin was exon 3. This is the one that has the highest risk of transformation to malignancy, and it's also the one that shows diffuse nuclear expression for beta-catenin. Sometimes these may also have mutations in exon 7, 8. These do not have such strong expression for beta-catenin or expression of another marker called glutamine synthetase. The last point I want to make is that more recently there's been an adenoma characterized by abnormalities in what's called the sonic hedgehog pathway. It has certain risk factors, specifically obesity, and it's important to recognize this because it has a greater risk of bleeding, or the patient may actually present with bleeding. So clinicians may want to resect this if the adenoma is subtyped as this type. And this table summarizes the risk factors, the clinical presentation, the histology, and the characteristic immunophenotype. I'm not going to move on to hepatocellular carcinoma. This is the most common primary cancer of the liver, and the age of onset depends on the geographic location and underlying risk factors. So, for example, in Asian countries where there's a high incidence or prevalence of hepatitis B infection, sometimes patients develop hepatocellular carcinoma before they've even developed cirrhosis and may develop hepatocellular carcinoma at a younger age than they do, for example, here in the United States, where the most common cause is hepatitis C with cirrhosis or else cirrhosis due to alcoholism. Patients who have known risk factors may be followed with screening, imaging studies, and also have serial AFP levels drawn. This is a characteristic imaging pattern of a hepatocellular carcinoma. Notice that it shows multiple nodules, so it shows one predominant nodule with some satellite nodules. This is the characteristic appearance. It shows a large nodule with hemorrhage and necrosis. And then over here is the characteristic histopathology, which shows widened trabeculae. The cells appear to be hepatocytes. We can recognize them by the abundant granular cytoplasm and the centrally located nuclei, but it's not your normal architecture anymore. We have widened trabeculae, and here we can see that they're surrounded by endothelial cells. So when evaluating a smear to try to determine if it's benign versus hepatocellular carcinoma, we should follow a stepwise approach. And typically, we can even start by looking at the slide, the gross appearance of the slide, and from there progress to evaluating the background at low power. And we can even evaluate the architecture at low to intermediate power, and from there progress to evaluating individual cytological features, such as the nuclear cytoplasmic ratio, the nucleation, nucleoli, and evaluating specific cytoplasmic features and contents. So, for example, this is an example of naked eye inspection. On the right, what happens with benign hepatic parenchyma, if it's an aspirate of, let's say that they stick the needle in benign liver, it tends to stick together here and form these cohesive core fragments. Over here, we see that this is an example of hepatocellular carcinoma where the tissue fragments essentially disintegrate and form a granular pattern. This is the classic cytology of hepatocellular carcinoma, and it recapitulates some of what we saw in histopathology. Here we see widened trabeculae. Here we see liver cells. We can recognize them as liver because they do have that typical granular cytoplasm. However, we'll see that there's an increased nuclear cytoplasmic ratio, and the nuclei here are more monotonous than what we see in reactive or benign liver. And then the periphery of some of these areas is smooth, and that's due to peripheral endothelial cell wrapping. Here's an example of the background. Typically, we may have a clean background. Notice the absence of inflammation or bile ducts in this field. A key component of hepatocellular carcinoma is the presence of strip nuclei. Here we see them on the diff-quick, nice round nuclei with some atypia. Here in the Papa-Nicolau stain, we can see them better. They're enlarged with prominent, significant nucleoli. So the presence of stripped atypical nuclei in the background is a feature of hepatocellular carcinoma. I've mentioned peripheral endothelial cell wrapping, and what exactly is that? Well, these images illustrate it. Here we have a group of malignant hepatocytes. You can see it's a very tight, crowded group with some nuclear overlapping. This represents a thickened trabeculae, and you can see the periphery is smooth. And right here is an endothelial cell, which shows the endothelium wrapping around this group. That's what makes it smooth. Here's another example. It's not as round. We see more of a widened trabeculae, but here along this edge, we can see the flattened endothelial cell. And if you see this finding in an aspirate of a liver mass is essentially pathognomonic for hepatocellular carcinoma, you can make the diagnosis of malignancy. And it would indicate hepatocellular carcinoma. Another vascular pattern that's not as Specific for hepatocellular carcinoma is called transgressing or arborizing endothelial cell pattern. At low power, we can see the group here. It's a little bit adhesive along the periphery, but we can see the vascularity in the middle. When we look at it more closely, we can see the capillaries and the endothelial cells traversing through the middle. Another architectural pattern is either referred to as the pseudoacinar pattern or the pseudoglandular pattern. We can see it on histopathology. The malignant hepatocytes are here. They're in a widened trabeculae with some peripheral endothelial cells again, but notice in the middle there's this widened space. It's not a true gland. It's what it is dilated or dilated canaliculi, but they do look like glands, and we can see this on cytology. For example, here is a pseudoacinar or pseudoglandular pattern. And down here is another example of that, which has been described, which is a microacinar pattern. So sometimes they're not as large as they are here. They might be smaller. But this is also a pattern to notice or recognize in an aspirate of a liver nodule. The other feature that can help us differentiate well-differentiated hepatocellular carcinoma from a benign liver nodule is that the cells become more uniform, and they developed an increased nuclear cytoplasmic ratio, as we see here. They still retain that granular cytoplasm that's well-defined and polygonal, but the NTC ratio is altered, and then these cells have this very monotonous appearance. Notice how similar they are in appearance and also over here. And notice that we have fewer bi or multinucleated cells, although we can certainly see them in hepatocellular carcinoma. And sometimes we even get nuclear pseudo-inclusions in hepatocellular carcinoma, as we do with hepatocytes with degeneration. And here are a few other subtle nuclear atypia, including some grooves. So to summarize, this table summarizes the differences in these benign nodules from well-differentiated hepatocellular carcinoma. We can start by looking at the slide at naked eye inspection, and then at low power under the microscope, assess for the background for bile ducts, inflammation, and strip nuclei. In hepatocellular carcinoma, the strip nuclei are going to be markedly atypical. In benign liver nodules, if we see them, they're going to be benign, typically not as numerous. We may see some transgressing endothelium or a vascular pattern in benign liver nodules. It's much more prominent and common with hepatocellular carcinoma. In addition, this peripheral endothelial cell wrapping pattern is only seen in malignant hepatocyte nodules. Again, architectural features are important. Benign nodules retain trabeculae that are 1 to 2 cells thick, and the periphery or the groups are going to be jagged and irregular. In malignant hepatocyte nodules, we'll see crowding of the nuclei, thickened trabeculae more than 3 cells thick, smooth borders, and pseudoacinar or pseudoglandular structures. The NTC ratio is significantly increased in hepatocellular carcinoma compared to benign. And hepatocellular carcinoma nuclei, when they're well differentiated, we see more of a monomorphic pattern with prominent nucleoli. The nucleoli are typically not as prominent in benign liver nodules, and benign liver nodules show more nuclear pleomorphism, that is more variation in size and in size of the hepatocytes and the hepatocyte nuclei. So moving on, if we can't really differentiate well-differentiated hepatocellular carcinoma from a benign nodule, there are a number of ancillary studies that we can use on a cell block or core biopsy. And these include special stains, particularly reticulin and iron stain. Iron stain is most useful if the patient has, for example, hemochromatosis. Reticulin is very useful on smears or cell block. Alpha-fetoprotein is expressed by hepatocellular carcinoma. The problem is that only about 40% overexpress or demonstrate expression for AFP in their cytoplasm. So if it's negative, it does not rule out a malignant process. CD34 was reported as being useful for highlighting the capillarization, but since that initial report, it's been identified capillarization is also seen in some benign nodules. So it's really not that useful to differentiate benign from malignant. And then there's a number of other markers that we can use, including glypican-3, beta-catenin, glutamine synthetase, and a marker that I don't think is very commonly used, HS heat shock protein 70. This is an example of reticulin in a normal liver nodule. You see that the reticulin is retained and surrounds the normal trabeculae. This is reticulin in hepatocellular carcinoma. It may either be completely lost, as it is here, or show variable expression and highlight the abnormal trabeculae or pseudoacini. A pitfall is a liver nodule with steatosis, because in steatosis, as you'll see here, the reticulin pattern is decreased. So if it's a very steatotic nodule or the cells are very steatotic, we need to rely on other markers to differentiate benign from malignant. This is an example of a liver nodule or a hepatocellular carcinoma expressing alpha-fetoprotein. It's strong and diffuse. So here it confirms that this is, we can tell it's malignant. We see a lot of nuclear atypia, but this confirmed that it was a hepatocellular carcinoma. Again, if it's negative, it does not rule out malignancy or hepatocellular carcinoma. CD34 was thought to be useful because it highlighted the capillarization of the sinusoids. Here we see an example of hepatocellular carcinoma, and we see strong expression of capillarization. And it also highlights the widened trabeculae. But there's two issues. One, a potential pitfall would be a very rare neoplasm called epithelioid hemangioendothelioma. You might get a liver biopsy in that too. We're going to see the malignant cells line the capillaries and will be positive for CD34. So that could be a pitfall if we let's say we don't interpret this stain correctly. But the other significant and practical issue is that capillarization is also seen in non-neoplastic liver nodules or malignant liver nodules. This is an example in a macroregenerative nodule with large cell dysplasia. You can see here it's overexpressed. However, in the cirrhotic nodule, we don't see expression. So this can be exploited to try to differentiate lesional tissue from non-lesional tissue when we have an aspirate or a biopsy of a liver nodule and we're not sure if it's benign non-neoplastic liver versus does it represent the actual nodule. So this article suggests starting off with CD34 to tell us if it's truly representative of the nodule, and that is it focal, maybe it'll be focal nodule hyperplasia or macroregenerative nodule, or is it just benign liver? So this is the way in which CD34 can be used. It's not really useful to tell us if a liver nodule is benign or malignant. Glypican-3, however, is more useful and indicated for differentiating benign from malignant liver nodules. It's upregulated in hepatocellular carcinoma. It's expressed more often in poorly differentiated hepatocellular carcinomas. So there's false negatives, and we may get some false negatives in well-differentiated carcinomas. But we could also use this to diagnose high-grade dysplastic nodules, since sometimes it's overexpressed in high-grade dysplastic nodules. The key here is that it's negative in benign hepatocytic nodules. I will also add that it's not useful for trying to decide if something is showing hepatocyte differentiation versus other differentiation, because other malignancies will express this marker. Beta-catenin is overexpressed in some hepatocellular carcinomas. So if we have nuclear expression for beta-catenin, it would also support either a beta-catenin activated adenoma or else a well-differentiated hepatocellular carcinoma. Glutamine synthetase has also been shown to be very useful for diagnosing hepatocellular carcinoma. It has varying expression patterns in the liver depending on the underlying disease or absence of disease. This table summarizes, and it's located in the perivenular areas in normal liver, and we might see some overexpression in cirrhosis. But there's three key areas that I want to mention. One, with focal nodular hyperplasia, it has what is called a map-like pattern, which I've illustrated here. It might also be, but the key of glutamine synthetase, if we're trying to decide if something is benign or malignant, is that if it's a truly malignant liver nodule, it's going to be strongly and diffusely expressed. So we can add this as a panel to, for example, glypican-3 to assess for malignancy. So I've shown you some examples of what is a diagnostic for well-differentiated hepatocellular carcinoma, but the question is, when is an aspirate indeterminate? So we can certainly use all the tools. We can use cytomorphology and then correlate it with ancillary studies to reach a definitive answer, but sometimes we won't be able to do that, particularly if we have only focal evidence of atypical hepatocytes with transgressing endothelium, and we don't have peripheral endothelial cell wrapping, and we don't have enough tissue for ancillary testing. So in situations such as these, we may not be able to give a definitive diagnosis if we only have these representative areas such as these limited to part of the smear. So to summarize the utilization of ancillary studies for benign versus malignant, we can start off with reticulin, but remember a pitfall is if the tissue or the tumor shows abundant clear cytoplasm, then we can't be sure if the reticulin is truly lost or if that's a false negative. Iron is useful for patients who have hemochromatosis. Really, the two best markers are glypican-3 and glutamine synthetase. Heat shock protein 70 has been reported, but I don't think it's routinely used in many laboratories. CD34 will show increased capillarization, but again, a pitfall is that typically we may see some capillarization in adenomas and focal nodular hyperplasia. It's really only useful to tell us if the liver tissue is lesional or not. So I showed you a typical well-differentiated hepatocellular carcinoma, and I want to mention that there are a number of morphologic variants, and I'm going to focus on the two most relevant. The first of these is the fibrolamellar variant. It accounts for about 1% of hepatocellular carcinoma and occurs in a lower median age range. Typically, it occurs in a normal liver, that is a liver without any underlying disease processes. The prognosis is similar to hepatocellular carcinoma. It's characterized by the presence of fibrous tissue fragments and malignant hepatocytes that have abundant granular, well-defined cytoplasm. It typically more often has single cells. It has this fibrous tissue or else transgressing endothelium, but this morphologic subtype will not have peripheral endothelial cell wrapping. The smears may be scantily cellular because of the extensive fibrosis. The nuclei will show intranuclear pseudo-inclusions or else prominent nucleoli. The other variant that I think is worth mentioning is the clear cell variant. This accounts for about 3 to 7% of all hepatocellular carcinomas. It has a significant clear cell morphology due to glycogen or steatosis. And supposedly it has a better prognosis. And the key issue with this may not be identifying it as malignant, but the fact that the differential diagnosis might include a metastatic malignancy such as renal cell carcinoma. So here we see a cluster of cells with a vascular pattern, and the cytoplasm seems a little bit clear and vacuolated. Here on the Papanicolau stain, we can more clearly see the clear cytoplasm with the centrally located nuclei. On histopathology, we see centrally located nuclei with very clear cytoplasm, either a large vacuole, as we see here, or numerous smaller vacuoles. And hepatocellular carcinoma shows varying degrees of differentiation. I showed you mostly well-differentiated hepatocellular carcinomas, which might be difficult to diagnose. And moderately differentiated carcinomas are easier to diagnose both as hepatocellular and as malignant. When we get into the area of poorly differentiated carcinomas, which might only have a dispersed cell pattern or very significant pleomorphism, it's going to be more difficult to recognize these cells as hepatocellular in differentiation. And then the differential diagnosis is going to be with other malignancies, such as even possibly cholangiocarcinoma or metastases. And I'm going to say a brief word about hepatoblastoma. This is a very, it's an uncommon neoplasm, but clearly the most frequent malignant liver tumor in children, occurring from 6 months to 5 years, but it may also be seen in the prenatal, neonatal age ranges or older children, rarely in adults. And the cytomorphology recapitulates the histomorphology, and it's usually a combination of cells with a fetal pattern. They look like hepatocytes, but they're smaller cells with a higher N/C ratio and a small amount of granular cytoplasm. Sometimes the cytoplasm may contain fat and glycogen, just as hepatocytes, or else they may have a less differentiated component called the embryonal cell component that has a higher N/C ratio and lacks cytoplasm and will lack the cytoplasmic contents. Those cells will form rosettes and trabeculae. And then sometimes there may be a mesenchymal component combined here that may vary in its differentiation. This is something to suspect if in children, or perhaps mostly in children. I'm going to move on to the diagnosis of cholangiocarcinoma. And there's a few points about cholangiocarcinoma that I would like to make. The first of these is that cholangiocarcinoma can arise anywhere in the biliary system. And we divide the biliary system into the extrahepatic biliary tree or the intrahepatic biliary tree. And within, so I'm going to focus on the intrahepatic biliary tree. And when we talk about intrahepatic cholangiocarcinoma, there are the ductal systems are separated into the large intrahepatic bile ducts, which are the bile ducts closer to the hilum of the liver. And then as the bile ducts are branch, they become smaller and smaller. They become smaller and represent the septal and interlobular branches of the biliary tract. And these are considered the small intrahepatic bile ducts. So when we see an image, cholangiocarcinoma may either present as a large mass-forming lesion. More commonly, this is how the septal or an intralobular cholangiocarcinomas present, or else it may present as an intraductal growth pattern, or else as a periductal infiltrative pattern, which may eventually go on to form a mass lesion. So these two patterns are the ones we're likely to encounter on FNA. With the intraductal pattern, we're more likely to encounter that on a brushing unless it progresses to form a large mass that can be a target for FNA. I just want to make one comment that there are different morphologies. These small and large duct cholangiocarcinomas have different, different morphologies. The small duct type is characterized on histopathology by some cholangiocarcinoma pattern or a ductal plate malformation pattern. The large duct type is a typical adenocarcinoma, but in the large duct, we also get some variant morphologies that we see in other organ systems like the adenosquamous or mucinous carcinoma, signet ring cell carcinoma, clear cell carcinoma, mucoepidermoid, or lymphoepithelioma alike. For today, I'm going to focus mostly on typical adenocarcinoma patterns, which is what we're more likely to see on fine needle aspiration. But you should be aware that cholangiocarcinoma can have a variety of other patterns, and that you may also encounter these on cytology, and that those other patterns do not exclude a primary carcinoma diagnosis. In terms of bile duct cancer, the typical pattern is that of a gland-forming malignancy surrounded by abundant desmoplastic stroma. Typically, it occurs in older patients. The patients present at an advanced age. There are a number of predisposing factors. Most of them are inflammatory, so either hepatitis B or C, or cirrhosis, or primary diseases of the biliary tract characterized by inflammation. But the typical morphology is that of an adenocarcinoma. Here we see a group of malignant glands forming an aborted acinus here, and the cells are more elongated and columnar. This is a pattern of a typical cholangiocarcinoma. At low power, we see a well-defined glandular appearing group, maybe with a gland formation here at the periphery. When we look at the cells, they have some variable nuclear atypia, and it seems like there's cytoplasmic mucin present. Again, we can see large nuclei with prominent nucleoli and slightly higher grade cholangiocarcinomas. We can see cytoplasm with a cytoplasmic mucin vacuole. Here, the cytoplasm's a little clearer. Here's a diff quick where we nicely see the cytoplasmic mucin vacuole, and in the background, we see evidence that there are some histiocytes and probably some ongoing necrosis. So really the typical pattern of a cholangiocarcinoma that we're going to encounter is an adenocarcinoma. So one challenge on an FNA of a liver nodule will be to differentiate hepatocellular carcinoma from intrahepatic cholangiocarcinoma, which is an adenocarcinoma. And if we're lucky enough, the hepatocellular carcinoma will have bile pigment in the cytoplasm or within or externally. Unfortunately, this doesn't happen very often, and this is a very old image. I have not really seen bile in a hepatocellular carcinoma recently. So it's very uncommon. But again, cholangiocarcinoma is going to be characterized by glandular differentiation and abundant cytoplasmic mucin. We can see this also on cytology. The other thing about glandular cholangiocarcinoma is it's not going to have the vascular pattern that we see in hepatocellular carcinoma. So you can see here the cells are columnar and they seem to have cytoplasmic mucin. Notice the absence of vascularity as we see over here. Here we see the transgressing vascular pattern, and here we see the peripheral endothelial cell wrapping pattern. So these patterns would exclude cholangiocarcinoma. The other thing which we typically don't see in intrahepatic cholangiocarcinoma are those stripped atypical nuclei. So gland formation, intrahepatic cholangiocarcinoma, a vascular pattern, either transgressing or peripheral endothelial cell wrapping, it's hepatocellular carcinoma. Cytoplasmic mucin, again, cholangiocarcinoma, bile pigment, hepatocellular carcinoma, and stripped nuclei, hepatocellular carcinoma. If it's a very poorly differentiated neoplasm and we don't have those characteristic features to help us, we're going to have to rely on immunohistochemistry. One key difference is in their cytokeratin expression. Classically, adenocarcinoma expresses high molecular weight cytokeratin. You'll notice this is an adenocarcinoma. The benign liver is negative. Malignant hepatocytes only express low molecular weight cytokeratin. So splitting the cytokeratins up front could help us with a differential diagnosis. Also, we can rely on markers of that might demonstrate a canalicular pattern, such as CD10, seen over here on the left, and polyclonal CEA seen over here on the right. In hepatocellular carcinoma, the polyclonal CEA will only demonstrate a canalicular pattern, whereas the adenocarcinoma is going to demonstrate a diffuse cytoplasmic pattern. So either CD10 or polyclonal CEA, if they show a canalicular pattern, can point us in the direction that this is actually a hepatocellular carcinoma. More commonly, I think today we rely more on markers of hepatocytic differentiation to include HepBAR and arginase. They're both very useful. Arginase is considered to be more sensitive and specific. The HepBAR tends to be lost in poorly differentiated hepatocellular carcinomas. The other problem with HepBAR is that other malignancies may also express it. So again, when looking at a case, we have to look at the cytomorphology in conjunction with the imaging and clinical features to determine if it's truly a hepatocellular carcinoma versus possibly a metastasis that's expressing HepBAR. For that, arginase is preferred because it's more sensitive and specific, but some well-differentiated cancers don't express arginase. MOC31 is a useful marker of glandular differentiation. So if we're evaluating a liver nodule and we're trying to decide, is it hepatocytic differentiation or glandular, we could start with MOC31 and HepPAR. If it's MOC31 positive, it's probably an adenocarcinoma or cholangiocarcinoma and not hepatocellular. If it's negative for MOC31 but positive for HepPAR, then we're likely dealing with hepatocellular carcinoma, and we can add other markers as needed to further the differential diagnosis. So moving on, another key challenge in the differential diagnosis of liver nodules, and it's one that we frequently face here at our cancer center, is distinguishing primary liver cancers, poorly differentiated hepatocellular carcinoma from cholangiocarcinoma, and cholangiocarcinoma from metastases, either metastatic adenocarcinomas or other metastatic malignancies that in fact actually may look more like hepatocellular carcinomas such as renal cell carcinoma and adrenocortical carcinoma and melanoma. In terms of metastatic adenocarcinomas, it's particularly challenging to determine if an adenocarcinoma in the liver is a primary cholangiocarcinoma or if it's a metastasis, mostly because few metastatic adenocarcinomas have distinct morphologies. So here I'm showing two examples. This is a metastatic breast cancer, lobular breast cancer, showing a linear arrangement, which is characteristic of lobular carcinoma. And down here we have the characteristic pattern of colorectal carcinoma, adenocarcinoma with columnar cells and extensive background necrosis. But in the absence of these classic morphologic features, we can be really challenged to determine, is it primary or metastatic? To that end, over the years, there have been a significant number of markers identified that can be used to define primary site of origin. And I've summarized them in this table. We can use the CK7, CK20 profile. CK7 negative, CK20 is very specific for colorectal carcinoma. I sometimes use cytokeratin 17 to guide me to decide if it's pancreatic or not, although I'm not certain how truly specific it is for a pancreatobiliary origin. Certainly loss of DPC4 is seen in pancreatic primaries. There's a number of markers we can use for gastrointestinal origin, TTF1 and napsin in lung. And here we have a number of markers for breast, prostate. GATA3 is useful for urothelial carcinoma. SATB2 is a newer marker that's specific for colorectal and appendiceal markers, in addition to osteoblastic tumors. If we're trying to decide if it's renal cell carcinoma or a female genital tract primary, we can use PAX8. Thyroid primaries can be PAX8, TTF1, or thyroglobulin positive. In situ hybridization for HPV can be useful if we're trying to determine if something's a lower anogenital tract primary or a metastatic oral primary or certain oral primaries. There's really not a marker, there wasn't a marker specific for intrahepatic malignancies until this novel branch DNA-enhanced albumin RNA in situ hybridization technology was reported. And this particular assay is supposed to be very sensitive and specific for primary liver cancers, specifically hepatocellular carcinoma and cholangiocarcinoma. So the initial studies were very promising. Since then, this albumin test has shown expression for albumin in adenocarcinomas of other primary sites. Before this publication, it was known that it could be expressed by acinar cell carcinoma. But it may also be expressed in a number of other adenocarcinomas or primary sites. Here we see breast, gallbladder, gastroesophageal, a pancreatic case. We see that only 81% of intrahepatic cholangiocarcinomas were positive, and a few lung cancers, and also this yolk sac tumor, which we probably would expect it to be positive. So the bottom line here is it's not going to be as specific as initially hoped, but we can certainly add it on as a panel and use it part of a panel and also combine it with the imaging findings. So if the imaging findings show a solitary liver mass and no primary elsewhere, and then this test is positive, then we can certainly conclude that this is the adenocarcinoma represents a liver primary. I want to review a few hepatocellular carcinoma lookalikes because I think this is particularly challenging also on FNA of the liver. There's a number of entities that can mimic hepatocellular carcinoma. This includes renal cell carcinoma and adrenal cortical carcinoma. Angiomyolipoma is a very unusual primary neoplasm of the liver. And also we have to consider entities such as malignant melanoma, hepatoid adenocarcinoma is metastatic to the liver, hepatoid yolk sac tumor, and sometimes even oncocytic variants of thyroid follicular carcinoma can mimic hepatocellular carcinoma. I'm going to focus on 2, renal cell carcinoma, because this is a very common challenge. And the reason it looks like it can mimic hepatocellular carcinoma because it forms this it may also be very vascular and have this transgressing endothelial cell pattern. Notice that there are numerous cells in the background, although we don't see it may also have atypical strip nuclei, although we don't see as many of them in this particular field. The clear cell variant has abundant cytoplasm with that's microvacuolated, and they have large prominent nuclei with micronucleoli, and certainly this can mimic the clear cell variant of hepatocellular carcinoma. Fortunately, immunohistochemical studies are very useful. The other entity that could be challenging would be metastatic adrenal cortical carcinoma, though fortunately adrenal cortical carcinoma is very rare. It can metastasize to the liver. In this low power image, we see that it's very vascular with numerous single cells and strip nuclei in the background, so it can certainly mimic hepatocellular carcinoma. Here we see round uniform nuclei with somewhat variable granular cytoplasm. Sometimes this particular neoplasm can be particularly challenging because it can show a smooth border as we see here. It can be vascular and have a pattern that mimics the peripheral endothelial cell wrapping pattern of HCC. So this is the one neoplasm that can really, I want to say, trip you up on cytology if you're not aware that the patient also has an adrenal mass, because the vascular pattern can really form this smooth peripheral borders, mimicking that peripheral endothelial cell wrapping pattern. This is a cell block showing that pattern. So, but again, fortunately, we can use immunohistochemistry to help us. We can use low molecular weight and high molecular weight cytokeratins. Also, polyclonal CEA or CD10 will show a canalicular pattern in hepatocellular carcinoma. We can use hepatocellular markers. Adrenal cortical carcinomas, positive for synaptophysin, MART1 and inhibin, negative for cytokeratins, but positive for vimentin. We could also use, for example, Paxate and CA9. This will be expressed in renal cell carcinoma and not in the other malignancies listed here. So when if we're not sure, immunohistochemistry can certainly help us with the differential diagnosis. So to sum this up, the diagnosis of hepatocellular carcinoma relies on architecture, cytomorphology, and background features. The presence of peripherally wrapping endothelial cells is pathognomonic for HCC and will differentiate well-differentiated HCC from benign nodules. Other vascular patterns are not as specific. We may see it in both benign or reactive nodules and also in metastatic malignancies, such as renal cell carcinoma. We need to rely on a normal hepatic plate supports malignancy, and we can highlight this with a reticulin stain and CD34. There's a number of markers that are useful either for recognizing a nodule as being hepatocytic in differentiation, such as HepPAR and arginase, and a number of other markers that can tell us if it's benign or malignant, including glypican-3, beta-catenin, heat shock protein 7D, and glutamine synthetase. And usually when we're diagnosing intrahepatic cholangiocarcinoma, we have to rely on the clinical history and imaging. This in situ hybridization test for albumin is promising, but as we can see now, it may not have the sensitivity and specificity that I think that was originally reported. So I want to move on to doing a couple of cases to try to emphasize some of these points. The first case is that of a 35-year-old female who was on oral contraceptives. Imaging was performed because of abdominal pain, and a round, well-defined mass was identified in the liver. This is somewhat of a high-power image of the diff-quick stain. We see that this is a collection of hepatocytes. You can see the polygonal cells with granular cytoplasm, but you can see they also have clear cytoplasm in some areas, and we can see that there's transgressing endothelium here. Papa Nicolau, the cells, I'm showing you a field with a more dispersed cell pattern. They have a low nuclear to cytoplasmic ratio. So please, can you launch the poll, Joanne?
Okay, I'll read out the answers. Select
Okay.
one of the following: hepatoblastoma, angiomyolipoma, benign hepatocytes consistent with adenoma, and well-differentiated hepatocellular carcinoma. We'll give you a few more seconds to answer, and then Joanne could share the poll. All right. So vast majority says benign hepatocytes consistent with adenoma, followed by well-differentiated hepatocellular carcinoma and angiomyolipoma.
Okay. So I think I'll go back and review this. Perhaps the person thought it was angiomyolipoma because of this vascularity and the clear cells. In angiomyolipoma, we do get fat-containing cells. So I think this field maybe was a little bit challenging, but this really does represent hepatocytes with steatosis in them. And then the next field, and notice that the periphery is jagged and irregular. We do not have that smooth peripheral border that I've described in hepatocellular carcinoma for those of you who thought this might be hepatocellular carcinoma. And here we see single cells. And I know the background seems a little bubbly, but sometimes if we have steatotic hepatocytes and they rupture, the fat does get released into the background. But these cells are hepatocytes and not lipocytes, as we see, or fat in angiomyolipoma. Here we have a hepatocyte with well-defined granular cytoplasm, and actually all of these cells are hepatocytes with a large centrally located nucleus. Here they have somewhat prominent nucleoli, but notice that we have we lack wide intraveculae. We have some single cells. Notice the very low nuclear cytoplasmic ratio. So these are features that support these being benign hepatocytes and not hepatocellular carcinoma. So I'm going to move on to the second case. The patient is a 66-year-old male with a history of cirrhosis. He has a rising alpha-fetoprotein and he's been followed. Imaging shows a new liver mass. And our interventional radiologist did a core biopsy, but here we do perform touch imprints for on-site adequacy. So this is an example of one of our cases. This is the low power view, and you'll see that the smear is very cellular with very large, somewhat cohesive tissue fragments. And here we have smaller fragments and some single cells, and here even maybe some stripped nuclei. Notice that there are no bile ducts in the background. The cells appear somewhat monotonous in appearance. That means they're all about the same size and shape, and they have a slightly increased N to C ratio. Here we see a higher power image with the cells have prominent nucleoli. You can see the high N to C ratio. I'm not sure if I'm supposed to describe them, but I did. So what is your assessment? The polling can start, yeah.
Thank you for the tips on that case.
Yeah, I know. I think I gave it away. I think I should have just showed you the images, but okay.
So what is your assessment? And here are the options: benign hepatocytes, liver adenoma, hepatocellular carcinoma, and cholangiocarcinoma. So again, we'll give a couple of seconds for you all to be able to answer the poll. And then we'll ask Joanne to share the poll with us. Okay, the poll is out and the overwhelming majority says hepatocellular carcinoma. I think you have taught us well.
Okay. All right. That's good. And then I'm going to move on to the third case, and then I think we can open it up for questions. Oh, so anyway, but this is the corresponding core biopsy of that case, and it shows hepatocytes in white intrabeculae. Here we even have a mitotic figure. So you see the hepatocytes have abundant granular cytoplasm, centrally located nucleus with a prominent nucleolus. This is an endothelial cell wrapping. Here we have another one wrapping around this white intrabeculae, and here we have a few more. So this is what it looks like on histopathology. We did a HepPAR, which confirmed that these were indeed hepatocytes. And this is an example of the reticulin stain in practice. You can see that this is more of the variable reticulin pattern showing a decrease in the overall reticulin expression, and it demonstrates the white intrabeculae, confirming that this is malignant liver, malignant hepatocytes. And so this last case might be a little bit tricky, but let's see how everybody works through it. So this was a 67-year-old male. He presented with both a kidney mass and a liver mass. He had no existing history of liver disease, but the FNA was performed with a liver mass. So the hint here is that there was no history of liver disease. No history of cirrhosis or hepatitis B or C or anything. So this is the cytology. This is on the DiffQuick, performed for on-site adequacy. I'm not going to describe it this time. This is the Papa-Nicolau stain, a representative field, representative high-power field showing the cytomorphology, the cytoplasm, and the nuclear features. And this is the background. We have some strip nuclei with really huge, prominent nucleoli. So I'm ready to open up the polling. This one's might be a little challenging at first.
Let's see, beautiful pictures, by the way.
Thanks.
So what is your assessment? Poorly differentiated adenocarcinoma, clear cell variant of hepatocellular carcinoma, metastatic renal cell carcinoma, and liposarcoma. Those are your options. Again, a few more seconds for you to fill out the form. Share. Okay, again, the vast majority says metastatic renal cell carcinoma, followed by clear cell variant of hepatocellular carcinoma.
Okay, so that's very good that you picked up on that. That's probably a metastatic renal cell carcinoma. Now, what have I showed you? This is an older case before we had Pax8 and everything else, but the tumor was, this is the CD10 stain. So now based on this immunophenotype, can we open up the polling again? I know I didn't provide the question to Joanne, but can you reopen the polling for the participants? It's the same set of questions that I just showed. Can you do that?
Joanne, would you be able to?
No, I can't do it. I have to have the question in ahead of time.
Oh, okay, because it's the same question I just showed.
Right, because it was already used though.
Okay, well then never mind. But now with the CD10, so this shows, so let's go back. So very good. This shows malignant cells with abundant cytoplasmic vacuolization and big round nuclei with prominent nucleoli. So this microvacuolated pattern is indeed very typical of clear cell renal cell carcinoma, although we can also see a similar pattern in clear cell hepatocellular carcinoma. This did have an endothelial pattern, which is not prominent here. Here we nicely see the clear cytoplasm and the prominent nuclei with the prominent nucleoli typical of renal cell carcinoma. And then we have the numerous strip nuclei with prominent nucleoli, which again can be seen in renal cell carcinoma, but also remember this can be a feature of hepatocellular carcinoma. But the key in the history was the fact that the patient had both a kidney mass and a liver mass and had no underlying liver disease. So in this situation, the clinical history kind of sets us up for the fact that this is more likely to be a metastatic renal cell carcinoma instead of a primary hepatocellular carcinoma. But on morphology alone, we certainly have to consider that differential diagnosis. The only way we can differentiate them is using immunohistochemistry. And in this case, again, I'm showing a CD10, which shows strong cytoplasmic staining. If this were hepatocellular carcinoma, the cytoplasmic staining, the CD10 staining would be limited to the intercanalicular spaces. Currently, other markers that we can rely on that I think are more specific are PAX8 and CA9, and that's what we're using in this institution. So just to show you in comparison, this is the canalicular pattern if this had been a hepatocellular carcinoma. And also if we had done HepPAR, it would show a granular focal pattern in a clear cell hepatocellular carcinoma, but it would be negative in a renal cell carcinoma. So with that, I'm going to close up my presentation. I guess can we open it up to questions?
Yes, definitely. Okay. Open it up to questions, and I'm going to go through these questions as we go on. So one of the first questions that you got was about mitosis and finding mitosis or mitotic figures, I should say, in cytology smears. Does that make you think of malignancy is the question. And I just think of Dr. Tina Fanning, who taught me in fellowship. She used to say, cells gotta grow, you see mitotic figures. That just rings in my ears. But what do you think about mitotic figures in?
Could you repeat that, because you were the transmission got disrupted for me, so I couldn't hear everything that you just said. Tina Fanning.
Absolutely. Yes, Tina Fanning, who he's retired from MD Anderson right now, used to always say when, as a fellow, you would get excited about mitotic figures and you'd be like, look, Dr. Fanning, here's a mitotic figure. And she'd say, oh, cells got to grow. You do see mitotic figures in growing cells, so don't get overly excited about mitotic figures, she used to say. It just reminded me of that.
Yeah, and I agree with that. The liver is damaged. It has to proliferate and repair itself. So we can certainly see benign mitotic figures in a benign process, although the proliferation index of benign nodules is going to be low. Certainly, we see atypical mitoses. It's going to confirm that that's clearly indicative of a malignant process, but a mitotic figure in and of itself is not enough to determine if it's benign or malignant. And I don't rely on proliferation indices either to help differentiate benign from malignant.
Mm-hmm. Here's another question. So like the case one that you showed us, the adenoma, in your final diagnostic line in practice, how do you verbalize this? Do you say benign hepatocytes consistent with hepatocellular adenoma or adenoma? How do you put that in verbiage?
So if it's a pure population of benign appearing hepatocytes and it without bile ducts or without bile ducts, then we can certainly, and let's say the imaging, it's relayed to us that the imaging is suggestive of adenoma, then we can certainly correlate it and say that, the findings are consistent with an adenoma. If I only have cytology and I can't I don't have any kind of microhistology in which to do additional ancillary studies.
Mm-hmm. Okay. So you say consistent with based on what they say?
Yeah, I think it's really important to correlate it with the imaging studies. Mm-hmm. And then again, sometimes it can be misleading because some bile ducts may be picked up from adjacent liver when they're going in to sample the nodules. So sometimes we don't always get that really nice aspirate of just benign liver cells without bile ducts to suggest an adenoma.
Here's another question from one of the participants. Should we ever mention the possibility of dysplastic nodules in cytopathology reports? Or if you do, how do you do that? Like small cell dysplasia or large cell dysplasia? What do you ever put that?
Right. So I didn't review that in this lecture. So there's two issues here. So there's what's called large cell change and small cell change. The most significant is small cell change, and that is hepatocytes with a high N to C ratio. The that are like some of the earlier foci of transformation to malignancy that may occur, for example, we'll see them on histopathology in a nodule of cirrhosis. And it's certainly possible that cells like that might be picked up on an aspirate, in which case probably we might see these focal cells with small cell change dispersed in a background of like a more benign appearing liver. In that situation, we might want to, be more descriptive, and we'll have to give an indeterminate diagnosis if we're only dealing with cytology. We might want to mention that we're seeing a small cell change. I think large cell change looks too much like reactive hepatocytes, and I think it's going to be very hard to pick up. It's also on cytology, and also I don't think it's as relevant in terms of it doesn't have as great a risk to progression to malignancy. Then in terms of diagnosing dysplastic nodules, there's certain size criteria. So I think the chance that, if it's a nodule larger than 15 millimeters, it's unlikely to be just a dysplastic nodule. It's likely to be a small hepatocellular carcinoma. So there's size criteria. And then also, the difference between a dysplastic nodule and a hepatocellular carcinoma will be in terms of the size of the trabeculae. The trabeculae won't be wide. We won't have pseudoglandular, pseudoacinar pattern. So again, for the high-grade dysplastic nodule, we might be able to suggest it if we see cells if there's clearly a nodule and we see a significant number of hepatocytes with small cell change, but we're missing some of the other features of hepatocellular carcinoma, such as widened trabeculae, or the pseudoglandular patterns that I've mentioned. But I think it's going to be really difficult to give a definitive diagnosis on cytology alone. It's in these areas where the microhistology is complementary. We can certainly, suggest it on cytology if it's in the appropriate clinical and imaging context. And we have some of the cytological features that I described. Does that help?
It definitely helps. That definitely helps. Yeah. Another couple of questions are on the usage or utilization of immunohistochemical stains. And the question is, how often do you do this? And if you do it in a cell block or FNA slides, or do you always have core biopsies? You do it on the core biopsy. How does it go?
Well, so lately our interventional radiologists have been switching more and more to doing core biopsies, in which case we have the touch imprints that I showed you for on-site adequacy. So in that situation, we certainly do the ancillary studies on the core biopsies. We can certainly do them on a good cell block if we have adequate material. And there have been situations where we haven't had enough material and we've done it on the smears. So it depends on whatever you have available.
Mm-hmm. How often do you get FNAs and core biopsies? I know that's a whole different sort of can of worms to talk about, but just curious, when you have FNAs of the liver, do they usually come with core biopsies or not really?
Yeah, I've not been tracking our absolute case volumes to give you an accurate number and representation. I know when I'm on site, sometimes I get an FNA of the liver. Sometimes they start with FNA, and if on-site adequacy is not yielding enough material, then they move to core biopsy. Sometimes they go straight to core biopsy, and I'm not completely sure what their algorithm is. It depends on the nature of the lesion, where it's located, if it's close to a blood vessel, and so on. Mm-hmm. Those factors will determine whether they start with an FNA or use only FNA, or whether they go directly to core, or whether I get both.
And when they do both, is it usually the same person who signs them out, or different people sign them out?
Right. So at this institution, because we're completely subspecialized, so I don't know if at Loyola or you have a completely subspecialized surgical pathology service. So because we're subspecialized, the FNA goes to the if it's an FNA only, it goes to the cytopathologist. Mm-hmm. The core biopsy if it's a core biopsy, it goes to the subspecialty pathologist. And what we were doing is that we were splitting the touch imprint and giving that. Let's say the patient had a core biopsy with touch imprint. The touch imprint was going to the cytopathologist, and their core biopsy was going to the GI pathologist Recently, we thought for the purpose of correlation, it would be preferable to have the surgical pathologist sign out both. I'm getting mixed results on that, but so that's our practice now. But if there's an FNA, the FNA goes to cytopathology.
Okay. All right.
But probably in centers that are less specialized, probably the entire specimen should go to one pathologist.
I think that might be a better idea because then you don't end up with two different diagnoses.
Well, so ideally, it depends. We do have access when we're on cytology. We always, almost always have a fellow or a resident, and typically that person looks up previous history for us and whether the patient has any corresponding pathology. And in addition, the cytotechs add that to the path report. So when we get our cytology reports, we know that there's a corresponding surgical pathology. And so usually we end up being the ones to reach out to our surgical pathology colleagues to let them know that we have a cytology specimen and to please let us know, or to correlate with us if sometimes their case is already signed out and we know ahead of time, and then we can comment. I think it could be better because, it should be more, I want to say a two-way street. I mean, sometimes, sometimes the people on surgical pathology, if they're not cytopathologists, don't always check to see if there's corresponding cytology. And it's not automatically flagged on their side. So that's why usually cytopathology in our institution usually puts in the upfront to do the correlation.
Yep, agreed. Yeah, I think that at the minimum there needs to be a correlation.
So we do it on our side,
That's great. I see one more last question, if you don't mind me asking, and I don't know if this is probably a very difficult question, and I don't know if you can actually do it, but can you possibly differentiate between focal nodular hyperplasia and a benign aspirate on cytology?
I think that's going to be challenging because they both are going to have similar components. So again, I think we need to rely on the imaging findings, and we need to be sure that they did sample the nodule, and then that the nodule shows maybe some of the characteristic features such as a central scar and it's well defined. Otherwise, on cytomorphology alone, we may not be able to say definitively that it's focal nodular hyperplasia and that they didn't hit like adjacent benign liver. Focal nodular hyperplasia is characterized by specific blood vessel pattern and specific appearance of the bile ducts. But I don't know that we can. I've not read any papers, or I've not had the experience myself of seeing that on cytology. And I do rely on microhistology to help me with that diagnosis.
Yeah, I second that. That would be very, very difficult. Well, thank you very much. This was a great lecture, very good review of liver cytology, difficult topic, and thank you for volunteering to do this. And
you're welcome. It was my pleasure. I'm happy I was able to do this and contribute to education.
Thank you very much. And also, I'd like to remind the listeners that tomorrow we have another educational webinar, and it's going to be on high-risk HPV testing, epidemiology, and QA uses. This will be given by Dr. Michael Henry from the Mayo Clinic. And the following day, on Thursday, again at the same time, we have a panel on the impact of COVID-19 and the laboratory procedures and personnel. So if you haven't already, get on it and register for it. And hopefully we'll get to see you again in the next 2 days. And until then, stay safe. Bye now.
Bye. Thank you, Louise.